Hello, everyone. Thank you for joining us for this marketplace room on sexual reproductive health and family planning. As you all know, the marketplace is one of the most interactive events of the summit, as we will be listening to stories, ideas, and projects that organizations around the world have implemented during this COVID-19 pandemic. We encourage you all to actively participate, ask questions, and share ideas with our presenters. Participant microphones are currently muted, but please use the chat box to type in your questions and comments during the presentations. If time allows, we will also open the mic for a couple of people to participate, but in the meantime, please send your questions through the chat. Our speakers for this session are McElwee and Abigail Sellman from Ideas 42 and Breakthrough Action, who will kick off this room sessions, followed by Dr. Gagan Gupta with panelists from UNICEF and WHO. And then last but not least, we will have Marian Wangari and Rashid Mutaha from HCD Exchange, Maisha Youth. I'll be sharing a bit more about our speakers before each session. So without further ado, I will hand it over to Ellie and Abigail from Ideas 42 and Breakthrough Action, who will be sharing encouraging family planning counseling that promotes meaningful choice during the COVID-19 pandemic and their experience around this in Malawi. Over to you, Ellie and Abigail. Please feel free to go ahead and share your slides.
All right, thank you so much, Ivani. Hi, everybody. I am Ellie McElwee, and I'm here with my colleague, Abby. So I'm just trying to see everyone's video while I do this. Okay. So thanks, everyone, for joining us today. We're going to discuss a project for provider behavior change in family planning counseling and how we adapted during COVID-19. As we move along, Abby will be monitoring the chat, so please feel free to add any and all questions as we go. As we begin, I want you all to imagine that you're a postpartum woman in Mchinga, Malawi. You go to your nearby health facility because you're ready to start using a family planning method. As you're waiting for your appointment, a nurse comes out with this map, hangs it on the wall, and gathers all the waiting women around. She tells you that she's going to share information about different family planning methods. Once the group picks a color, she will read information about a method and wants you all to guess which method it is. So now, please use the chat function to pick a color and then guess which method I'm explaining. Abby will tell me which color you all choose. Don't be shy, any color you want.
All right, we hear some blues.
Okay. If you use this method correctly, you can have your next baby whenever you're ready, in a short time or a long time. If you want to get pregnant, it might take up to 6 months after you stop this method. However, everyone's bodies are different, and some women could get pregnant sooner. You must return to the health facility every 3 months, or you must inject yourself every 3 months. You cannot forget to come to the clinic. You cannot forget or come to the clinic late, or this method won't be effective. Do you know what method this is? Please also put your answers in the chat.
Injectables, we hear injectables, injection, Diana press.
All right, I'm not surprised with the crowd. Yes, this is injectables, both Depo-Provera and Cyanopress. And the health worker would go into more information on these methods, but we're not going to do that for today. So in Malawi, there is a high rate of unmet need and discontinuation among postpartum women. Through formative research, we identified our problem statement that providers often fail to offer family planning counseling that clearly conveys the advantages and disadvantages of all methods in a way that supports meaningful, informed choice. The providers were giving counseling, but the information wasn't resonating with the women. Our project is particularly focused on family planning uptake for postpartum women in the districts of Lilongwe and Mchinga in Malawi. Through in-depth behavioral research, including interviews, focus groups, and observations, we used insights from behavioral economics and social psychology to uncover 7 behavioral barriers contributing to this suboptimal counseling. We'll just discuss 2 today that hold true in the context of health provision under COVID. First, providers use faulty heuristics or mental shortcuts that result in presenting biased and inconsistent information on the advantages and disadvantages of each family planning method. One feature we observed in the environment that led to this was that providers generally start family planning counseling by asking women which methods they know about. And in Malawi, there are high rates of Depo-Provera usage, followed by the pill. Thus, most women know about short-term methods and say so, leading providers to focus on these methods during their health talks and consultations. The second barrier we found is that providers counsel on particular methods based on assumptions of women's needs. And these assumptions, while allowing providers to serve women more quickly, do not help women choose the method most aligned with their fertility intentions. One cause of this barrier is providers' belief that if a woman wants to have another child in less than 3 years, which is less than the maximum effectiveness of LARCs, then she should be using a short-term method, like the pill or injections, or she would be wasting a LARC by removing it before it expires. So this leads us back to our counseling tool, which uses random selection of colors to de-bias the order in which methods are presented and gives information on factors that are important to women, like when they can get pregnant again and how many hassles they must go through to get and use the method of their choice. So please choose another color, different than blue.
Green.
Green, all right, here we go with green. If you use this method correctly, you can have your next baby whenever you're ready, in a short time or a long time. When you want to have a baby, you can get pregnant right away after you stop the method. You must use this method every time you have sex. You must ensure it does not break and use it correctly in order to protect from pregnancy. Do you know what this method is? See how smart these women are.
Everyone is very smart and everyone is getting condoms.
All right, very good. Condoms, both male and female. We use our behavioral design methodology to design solutions that are directly linked to behavioral barriers to support providers in offering family planning counseling in a way that promotes meaningful choice for clients. For example, the interactive group counseling tool used at health talks and facilities. This tool works in tandem with a method referral card that allows women to follow through on getting her method of choice. When the COVID-19 pandemic hit, we were preparing to start a randomized controlled trial in two districts to test the impact of our solution set, thus had to rapidly adapt our implementation and evaluation strategy. Our original tools were designed for use in the health facility and followed women from A&C through their postpartum period to encourage family planning uptake. In looking at the counseling tool and referral card, they start with women attending a family planning consultation, E&C, or immunization clinic for her baby. At all of these consultations, the woman hears a health talk using the interactive counseling tool. The woman can then choose a method that is well suited to her needs, or something might prevent her from doing so. Perhaps the method she chooses is unavailable, or she's just not ready to choose. For both of these cases, the woman receives the method referral card, reminding her to think about family planning and come back another day, thus helping her follow through on her intention and getting the method of her choice. Since COVID made it impossible to continue testing our intervention in the health facilities, we saw an opportunity to adapt our tools and use them to help women continue accessing family planning counseling in their communities during the pandemic. Luckily, we had insights from our behavioral research as we had talked with community health workers during user testing of our original designs. Using these insights from our initial feasibility test and from user testing, we pivoted to working in the communities. We adapted our group counseling tool to be cards for one-on-one counseling in the communities. The cards maintain the randomization of the order the methods are discussed and keeps the discussion focused on the elements women consider when choosing a method. The cards are interactive, using gamified elements that are still novel in their design, hopefully generating interest in the practitioner community, as it did with the Malawi Ministry of Health. We were also able to continue with the referral cards, but for use in the community. As regular facility-based family planning services shifted to the community during the pandemic, We wanted to ensure that our tools would be used in a way that enabled the sustainable delivery of quality family planning services. As I shared, we adapted our tools to be used in the community context, and we are currently working with community health workers to implement and adapt the solution set with the assistance of family planning coordinators from Malawi's Ministry of Health. The community health workers are now using the cards to provide one-on-one family planning counseling to women throughout the community. And this is to help them choose a method. For women who are not ready to get a method or just want one that is not available, community health workers are using the referral cards to either give women a temporary short-term method, which are the only methods that community health workers can administer, and helping them make a plan to get another method at the health facility once COVID cases start decreasing, or referring women who want to take up a method that the CHWs don't provide to an outreach that is running during COVID, all of which help the women get the method of their choice, even during the pandemic. The community health workers were trained on how to use the solution set and how to protect themselves against COVID transmission while in the community. We are currently running a feasibility test on how these solutions work in the community based on phone interviews with the community health workers. So let's see another method. Which color would you all like to choose now?
Great, I hear orange.
Orange, all right. This method is non-reversible, and you should only use it if you're sure you do not want to have another baby. You or your partner must come to the clinic once, and then whoever gets the method is permanently protected against pregnancy for the rest of their life. Do you know what method this is?
Again, we have some smart individuals in this group.
Not surprised.
Vasectomy.
Yes, so that is the bilateral TBL, I always say it wrong, and a vasectomy. All right. Our ability to pivot and quickly adapt our solutions, like the group counseling tool, to the new context of COVID-19, stem from the fact that we did a lot of upfront user testing and ran a feasibility test in our solutions. User testing was valuable because it allowed us to see that the community health workers understood the tool and could easily work with it and learn how to use it. We also saw that the tools were desirable for community use, with a lot of facilities and in-charges asking to send them to the community during our first part of our testing. And we also were able to see which elements were most effective at improving counseling, allowing us to keep them in the adapted designs. User testing is showing prototypes of your design to the end user to solicit feedback and make changes. User testing deepened our understanding of how a variety of different actors engaged with the solution set and enabled us to make sustainable changes to the solutions while keeping the major elements that ensure that they lead to quality counseling. So I want to share with you some quick points about how user testing is a best practice for future intervention development, focused on service quality, especially as user testing components of an intervention allows for flexibility in unexpected circumstances such as the COVID-19 pandemic. The benefits of user testing go beyond simply developing a single intervention, but also position that intervention for easy adaptation. And so the goals of user testing when you're looking to do it are really seeing that the potential user is able to use your intervention. So it gives you a chance to get immediate feedback before you finalize your intervention. It also ensures that the intervention works in various contexts where you're going to be applying it. It tests the ease of use and the demand for the intervention and allows for rapid iteration on interventions. And so you really go into user testing before you finalize things. You bring your prototypes, which are drafts of what your final intervention will be. In order to conduct effective user testing, we recommend using these three tools. Here, it's written for an intervention to be used with a health provider with a client. So we have open-ended interviews, role play with a debrief, observations with the debrief. The interviews are most useful with early prototypes, so you can solicit feedback and people's responses to make quick changes. Make sure you avoid leading questions, as we know people will want to tell you what they think you want to hear. Role plays are useful with prototypes that are more refined, but still need some work. It allows you to see how the end user thinks the intervention should be used. They might even use it in a better way than you hadn't thought of. Observations of actual consultations are best with a more refined prototype. You can either make it a mock consultation or a real one if the client gives you permission. It's important to debrief separately so both parties feel at ease and don't try to say the other person did a good job. So now we're pretty curious if you can please share in the chat if anyone here in this group has actually had experience with user testing, and if you can share a little bit what that experience has been. While I go on to our last slide and we'll open up for discussion. So we're writing up a dissemination handover package to transition full ownership of these solutions to the Ministry of Health and Service Delivery Partners in Malawi. The dissemination package describes all of our solutions, including tools we developed to be used during ANC, but didn't discuss today. We're also looking to disseminate our solutions more widely and would like to use this opportunity to make our dissemination package available to everyone to develop new partnerships. At this moment, we're user testing the content and format of this handover package to optimize its usability. So please, in the next slide, note our contact information and reach out if you're interested. We're looking for people who are both interested in the handover package and would be willing to look at it with a user testing mindset to provide us with some actionable feedback. And Abby will be at the networking event later today if you want to talk with her. So with that, I want to say thank you and open it up to any sharing about user testing if people have done before, any questions about behavioral design or about this intervention, or for you all to share your experiences with COVID.
Okay, Ellie, we have one question, if you would like to answer it. So Anita asked, the CHWs know how to use your cards, but how deep is their knowledge on the different family planning methods, and who gives them ongoing professional support?
So this intervention has been rolled out with a partnership with MSH in Malawi, an organization called UNICEF. And they are really working to improve health worker knowledge and focusing on kind of the medical training and ensuring that we're doing the behavioral aspect and they're doing the very medical knowledge aspect, so they have the ongoing trainings, as well as working with the Reproductive Health Department and the Ministry of Health to ensure they're supported.
Great, we have one more question. A bunch of questions coming in, but one, Ellie, if you could answer from Sarah, what was the outcome of your behavioral design versus the previous method of education?
So we just did the feasibility test, so we don't have actual impact information yet, but we were seeing trends towards women starting to think about using a method earlier in their postpartum period. So really looking at immediate postpartum uptake and understanding that there were options available to them kind of before the 6-week benchmark that was very prevalent in Malawi. And that was kind of from anecdotal evidence with women interviews. And so hopefully in the future, someone will be able to test for impact.
I'll just add as well, 2 of the things we looked for in the feasibility test were, we did qualitative research with providers to ask them, what were changes you saw in women after the group counseling tool? And something that providers said across the board was that women are asking a lot more questions about a lot more methods. And in some cases, providers were really excited about that. And then in other cases, providers are saying, oh, this gives us more work to do now because we have to answer more questions. So that was quite an interesting finding. Another finding that we had as well was that for the method referral card, it was about 1/3 of all women who were attending family planning counseling were actually requesting this method referral card, which shows a really big demand for the referral card for women who want to think about other methods or women who might not be able to get their method. So I think that is quite an indication that this has some potential for impact in the future, even though we weren't directly measuring discontinuation or method mix or anything like that.
Right. And just to show you all the methods as we wrap up here, these were all the methods that are included in the counseling plan and counseling tool. and they are all covered by the end of the time. And the tool takes anywhere between 20 to 30 minutes, depending on how many questions the women answer and how familiar the health workers are with the content. And so I can answer any other questions in the chat. Feel free to chat me privately, and I will give it back to Ivani. Thank you, everybody.
Great, thank you so much, Ellie and Abigail, for this wonderful presentation on provider behavior change and family planning counseling. I'm now happy to introduce our next presenters, Dr. Gagan Gupta, Health Specialist, Maternal and Newborn Health at UNICEF, joined by panelists from WHO and UNICEF. He will be introducing his panelists, and they will be presenting on every newborn action, regional and country responses to the COVID-19 pandemic. Over to you, Dr. Gupta.
Thanks, Avni. Good morning, good afternoon, and good evening, colleagues. Wherever in the world you are, contributing in your own ways towards the global response to COVID-19. I'm Gagan from UNICEF, your host and moderator for today's session. We are at a unique crossroad today. As we move into the action decade of SDGs and the next 5-year phase of every newborn action plan, with time to press the accelerator further, we actually stand a real risk of losing all the past gains due to COVID-19, something of the magnitude none of us have seen ever before. With 100+ days into this pandemic, 10 million cases and 500,000 deaths already, lives truly stand in the balance today. Though mothers and newborn are not the face of COVID-19, they run the risk of being its biggest victims, largely due to lockdowns, disruption in services, and the economic slowdown. As we mount our response to COVID-19, it will be equally critical to mitigate its secondary impact and lend our collective voices to protect, preserve, and track the physical, financial, and human resources that are very much needed to deliver quality care to every woman and newborn. So with this background, over the next 20 minutes, we will bring you a glimpse of how the global newborn community is responding to this challenge and how all of this is translating into action on ground. For today's panel, we have Ornella Lincetto from WHO headquarters, along with UNICEF and WHO colleagues from 3 regions, Rajesh, Mehta, and Atnafu from South Asia, Fatima and Assumpta from Africa region, and Khalid and Tomomi from the Middle East and the Mediterranean region. So let me start with Ornella for the global perspective. Ornella, what do we know of the impact on the mothers and the newborn? And what has been the global response? Over to you.
Thank you, Gagan, and welcome to all the participants to this webinar. We know that millions of women and newborns today are at high risk of death and poor outcomes because than ever because of COVID-19. This is not is only due in small part is due to the direct effect of the disease. Is much more is due in fact to the impact of COVID-19 on disruption of essential services, reduced availability, access, and utilization. The slides shows, for example, the estimated extra maternal and child deaths due to indirect effect of COVID-19. You can see in blue the baseline maternal deaths in the upper part of the graphic and the child deaths in the lower part of the graphic. And in pink, you can see the additional maternal deaths and the neonate and child deaths that are due to COVID-19 in different scenarios. Scenarios with a reduction of a coverage of 5%, 10%, or 25%. These are huge numbers and are showing exactly what Gagan was saying, that the pandemic is actually threatening the progress we have done in maternal neonatal mortality reduction. Now, next slides. In terms of response, we have developed a number. We have developed a number of tools to increase access to maternal neonatal, to protect the maternal neonatal health services. So there is a tool on community-based healthcare, including outreach and campaigns in the context of COVID-19. There is the operational guidance for maintaining essential services in the context of COVID-19, specifically with the chapter on maternal and child health services. We have also tools, guidance to reduce the spread of COVID-19 and improve care of affected people. For example, the clinical management as a special chapter on management of pregnant and lactating women or newborns with suspect and confirmed COVID-19. And then, of course, we have a research, we are coordinating a number of research to understand the pandemic, its effect on maternal neonatal health and develop solutions. And then on the next slides, you can, we are, as you know, with the partners at global and country level has achieved supported an acceleration of progress in the reduction of neonatal mortality and stillbirths we have seen in many countries. But COVID-19 pandemic is threatening this progress. And also the country efforts to improve maternal and neonatal health. So today, more than ever, we need to protect, we need to maintain and expand maternal and neonatal services. And to this end, we have defined recently the new coverage targets, enough coverage target for 2025 to be reached as we move towards in the path to 2030. It is critical to achieve those targets if we want to reach the SDGs and prevent in this way millions of maternal neonatal deaths and stillbirths. So we will launch the new enough targets early in August, and I count on you to participate. Thank you very much.
Thank you, Ornella. So let us now move into the regions where the action lies. And let me start with Sub-Saharan Africa, the region with the highest number and the rates of both neonatal and child deaths, and a region which is already under-resourced in terms of its health systems. So Assumpta and Fatima, how has the pandemic affected the maternal and newborn health services in the Afro region, including the surge of information and what we call as infodemic, and what has been the response? Your 4 minutes starts now. Over to you.
Thank you very much, Gagan and panelists. As the gravity of COVID-19 began to unfold, the governments of the region instituted lockdowns to protect their citizens. Here they closed all schools, they closed all borders, workplaces, everywhere. They even imposed curfew, especially to minimize contact. Then they began preparing to receive patients, because what we saw globally was hospitals and patients. So they repurposed most of the health services to respond to COVID. At the same time, they repurposed most of the health workers also to respond to COVID. They forgot about the norm, which still needed to continue and to be attended to. We began receiving reports from countries about maternal deaths, and this was coming through the media. So we reached out to countries to get the real situation and what challenges they were facing. What you see on the slide there on the right was the response from one country. You can see the reduction of the services between, when you compare two periods, 2019 and 2020 from January to April. There was a reduction, for example, of 4 antenatal visits of 50%. If you go to live births at facility level, there was a reduction of 21%, cesarean section. Also combined pills, you can see up to 90%. And so when we asked, or we looked at the challenges that they were facing, like I said, there was that repurposing and forgetting about the normal services. Then, of course, that resulted in the reduced access, as we see on the right side. Why? Because of fear, lack of inadequate information. People had no information. They just closed everything and no information. Of course, the curfews, inadequate IPC, and shortage and stock out due to disruption of services. Now that, of course, with the reduced prioritization, resulted in the results we are seeing. So there was also reported increased GBV, or gender-based violence, and without a lot of coping mechanism, in that the schools were closed, everybody was at home, nobody could go to school. They couldn't go to work. Those were places where they could escape from. So the issue also of stigma, because people again didn't know infection, they know people were dying, so nobody would want to expose themselves knowingly. So this led to a lot of misinformation and mispractice, for example, about breastfeeding and contact. Then also insufficient implementation of innovative strategies. And this we saw later as we started to respond, that we could institute some of this, like self-care, the digital health, and task sharing. I now want to pass on to my colleague, Fatima, so she can say the response that we have put in place. Thank you.
Thank you so much, Assumpta. Since the beginning of this pandemic, WHO, Afro, UNFPA, and UNICEF Regional Office for Eastern and Southern Africa have been contributing both at preparedness and response level. Just a small disclaimer, enormous work is ongoing both at regional and country office level. So, but just for the best interest of allocated time, today's focus would only be on some of our efforts at regional level. We have been providing well-coordinated inter-agency and inter-sectoral support to our countries, which means we are working closely with our sub-regional emergency case management teams. For example, regional maternal and newborn health team has contributed technically on the development of sub-regional overarching document on the continuity of essential health services. We also developed a comprehensive technical and operational document for the continuity of MNH services. We did not stop there. We are supporting country offices to adopt regional documents in their context, and for the dissemination of regional technical guidance, we have been conducting bi-weekly webinars. So far, we have conducted 7 webinars, and until today, more than 900 participants have benefited from our webinars. Work is in progress in developing a joint regional monitoring mechanism for the disruption of maternal, reproductive, and child health services. For advocacy, we are equipping our country offices with the recent evidences so that they can effectively engage their policy and decision makers to address barriers linked to access and quality of care issues. Lastly, on infodemic, we are closely working with our risk, communication, and community engagement teams to address issues linked with misinformation and rumors, which Assumpta just talked. I'll stop here. Thank you.
Thanks, Fatima and Assumpta. Coming now to South Asia, the region with the highest share of neonatal to under 5 deaths, with 62% of under 5 deaths happening in the neonatal period, much above the global average of 47%. So Rajesh and Atnafu, how have the partners come together to support countries in the region to continue essential services for MNH during the pandemic? Over to you.
Thank you, Gagan, and thanks to colleagues from Africa. They have just outlined the type of problems they have faced, the communities have faced in that continent. Southeast Asia and Asia regions of UNICEF and WHO actually are home to more than 25% of world's population. And in numbers, we have huge preventable mortality. So we had gained a lot during the MDG and the early part of the SDGs. 5 countries of 11 Southeast Asia regional countries of WHO member states, 5 had already reached SDG goal of under 5 mortality. And 4 of them also have reached the goal of 2030 goal of neonatal mortality. All of that is at risk because of the factors which we heard from Ornella and Africa colleagues. So disruption is almost a norm in our countries as well in Asia. So how we are helping countries is through partnerships, especially the H6, which is WHO, UNFPA, UNICEF, UNAIDS, UN Women, and World Bank. And out of those, the 3 big ones are here who are jointly supporting the country. We came to an agreement that all 3 agencies will help the countries in advocacy and guidance, and also help them to do some research management, document best practices. So we were the actually first ones in the regions, among the regions to issue the regional guidelines as early as middle of April this year, how to continue the essential services. And we are happy that national governments have used these guidelines to prepare national plans for continuation of essential services, realizing there is a lot of disruption of services which can be seen in several countries. So we are also helping the countries to ensure quality of care. We are helping them to prepare standard treatment protocols for positive cases, mothers and newborns. And we are also setting up registries for positive women and positive newborns and children, so that we can have an idea of clinical profile and outcomes in these children. Next, please. So we also are, Olive, if you can go to the next. So we also jointly finished this exercise of a baseline assessment of services. We wanted to understand a little bit in detail how the countries have reduced or modified some services, what is the impact on service delivery, and also we wanted to understand what are the health system factors. Have the MNH finances moved away from essential services to COVID? Have the workforce for the maternal newborn care, have they been sent away to COVID care? So what are the essential supplies for maternal newborn health? Somebody monitoring them or not? How is the HMIS working during this pandemic when health systems are overwhelmed? So we have a lot of information coming from countries. We want to do this every 3 months so that countries can design better plans. But also we are commissioned small studies in India, Bangladesh and Nepal to do a little bit of qualitative work. I have seen some comments in the chat box to understand how much financial burden has increased, how the economic failure has led to a decrease in service utilization, what is the stigma, what are the fears. So we are doing that study. But my friend Atnafu will take over from here to describe how do we help countries to do a dashboard for more frequent monitoring of essential services. Over to Atnafu from UNICEF.
Thank you, Rajesh, and hello, colleagues. The graph you see on the right side is actually a snapshot from a data-based dashboard UNICEF Bangladesh is producing for monitoring continuity of utilization of essential services. I mean, this dashboard basically tracks the absolute number of people, as you would expect, as well as coverage for each district, and also compares it with the same months last year, basically showing us the level of service disruption. We find it to be quite a convenient tool informing those programming and advocacy. On that line, we are working whatever is the national available health information system. On the next slide, please. Another important initiative we are pursuing is a combined model on both direct impact in outbreak as well as indirect impacts on MNH as well as that will be additional mortality on impacts on birth rate as well as child.
I think, Atnafu, we have lost you, but we move to the next thing. Sorry for this. So thanks, Rajesh and Atnafu. And this pandemic has also brought to the forefront the fragilities of the data systems, given the fact that still we have to rely more on projections and models rather than the actual data coming from field. And it's good to now see from two of the regions who spoke that some information is trickling in. With this, we now move to the Middle East and the Eastern Mediterranean region, the region that hosts the largest number of people in the need of humanitarian assistance globally, with more than half of the countries in the region affected by the prevailing humanitarian or emergency context. So Khalid, first to you. How does COVID-19 impact on newborn health differ in the emergency affected countries? And what are the key challenges you are facing in the countries in your region? Over to you.
Thank you, Gagan. As you may all know, that COVID-19 pandemic actually comes on top of already disrupted healthcare systems in most of the conflict-affected countries in our region. In many instances, even the basic health services for newborn are either not being there at all, or if they were there, they were either in poor quality or there is poor access to this aspect of newborn care services. In Yemen, for instance, where we witness the worst humanitarian crisis in the world, more than 50%, actually, more than 50% of the facilities are no longer functioning. This is even before the COVID pandemic. So you can imagine how the pandemic has further harmful impact on the health of newborns and children and mothers in these settings. And this is leaving hundreds of thousands of newborns deprived from essential care services. Also in a country like Syria, we can see that public health services are no longer functioning in many areas, and this brings private sector to the front, and we can see now many private hospitals are taking the lead in the management of newborn and mothers, even within COVID-19, without the presence of the public health services. Also, the issue of poor governance and coordination is another prominent issue crippling COVID-19 response, and specifically for newborn health and maternal health in our region. For example, in Yemen and Libya, you can see more than 2 authorities controlling different parts of the countries. This has resulted in some sort of uncoordinated response, inefficient use of resources, and also wasting of precious time that we need in our fight against the virus. And lack of precise data and information, and we can, yes, the lack of precise data and information also remains a key challenge in our humanitarian settings. But even with the limited data and information, we can see that the trend of coverage of essential services for newborns are going down. As you can see, for antenatal care beneficiaries or skilled birth attendants, the trend is going down starting March 2020. Another issue is data that it actually sometimes masks the conflict situation, masks the real burden of the disease. Also in Yemen, for example, we are seeing the highest case fatality rate in the world, but we are not sure if this is a real high case fatality rate or it is just because of the under-reporting of cases due to the conflict and due to the lack of access to data facilities. These are just a few examples of an endless list of challenges that we are facing in humanitarian settings in our region. Thank you. Over to you, Gagan.
Great. Thank you so much. And with this, we move to Chomomi. So Chomomi, would you like to please highlight some examples of joint response and partnership activities which are going on at the country level? Over to you, Chomomi.
Okay, thank you, Gagan. So in many countries in the region, the WHO, UNICEF, UNFPA, and other key stakeholders are collaborating to ensure continuity of MNH services by working together with the Ministry of Health to optimize service delivery setting, provide appropriate IPC measures, and procure PPE. So now we virtually fly to Syria. So as the crisis enters its 10th year, an estimated 11.1 million people in need of humanitarian assistance. The COVID-19 cases and deaths are still low, maybe due to weak testing capacities. Now, WHO and UNICEF are collaborating to adapt and translate the guidelines for breastfeeding and early newborn care. In addition, the trainings on managed care have been conducted in private hospitals where MOH has no reach to improve its quality of care during this difficult time. So now we now fly to Iraq. So the humanitarian context continues, and there are about 1.4 IDPs in Iraq. On top of this, now Iraq has more than 47,000 cumulative COVID-19 cases with more than 1,800 confirmed deaths. While managing the COVID-19 cases, 3 UN agencies, the WHO, UNICEF, and UNFPA at the country level, and also together with the regional level, have been collaborating with the Ministry of Health to grasp the situation by monitoring the service coverage at the health facility level, including the PHCs, using national health management information systems as shown in the slide. Now, based on this data, MOH and 3 agencies are now working together to develop a national guidelines on continuation of MNH services. So that's the 2 examples from our region. Thank you. Over to Gagan.
Thank you, Tomomi, so much. So as we conclude, I want to thank all the participants for their time, and to Olive and Mary for doing all the hard and heavy lifting, and to my colleague Chadba for her support and preparation of this. And sorry, Avni, for a bit over time, but as one of my professors told me in my early career, once you have the mic, never leave it. So here are also some of the links to the resources that you may like to use. And as I conclude, the message is loud and clear. Lives of millions of mothers and newborn are really hanging in balance today. And across continents, we all need to play our part to help the governments, communities, and those at the front lines to navigate through these uncharted waters. Stay tuned, more is coming, the launch of ENAP 2025 targets coming soon in August. Thank you so much. Over.
Great, thank you, Dr. Gupta, and thank you all for that insightful session and sharing with us your learnings and best practices from different regions around the world. Please feel free to continue to use the chat box. I know there were some great questions and discussion in there. I would next like to introduce our final speakers for this marketplace session. Next up are Marianne Wangari, HCD consultant, and Rashid Mutaha, Design Master, Maisha Youth, who will be presenting Voice Up, Sexual Health Information and Support in the Hands of Adolescents. Over to you, Marianne and Rashid.
Thank you. Thank you for having us. Good morning, good evening, good afternoon, everyone. Thank you so much for joining us. I am coming live to you from Nairobi, Kenya, and it's currently at 6:09, so slightly towards the end of the day for us. I'm gonna put on my presentation, share my screen. And with me, I have Rashid from Maisha Youth. He's gonna have an opportunity to introduce himself as we continue. My name is Marianne Wangari. I am a HCD designer based in Nairobi, currently working with HCD Exchange as a human-centered design researcher and consultant. And today we're gonna be sharing with you a project that we recently completed that is currently under the live prototyping phase. It's a 3 weeks design sprint that was very collaborative, and that's what we are gonna be walking you through. What was the process and what was the output and where are we in the project? So the project was a focus in quickly or rapidly coming up with solutions that allow organizations that are currently working in the ASRH sector to continue offering services to young people even during an ongoing pandemic, and especially here in Kenya where we are currently on a, I would say, partial lockdown and less movement within the country. So how do we ensure that adolescents and young people continue to access sexual reproductive health and services? So a little bit background about us. HCD Exchange is an active community of partners that are intentionally and committed to shared interest in human-centered design and adolescents' sexual reproductive health. In a nutshell, we are a community of practice that brings together various partners, so implementers of ASRH programs, youth-led organizations, so in this case, organizations that work with young people to offer ASRH services and information, and then designers, a collective of designers that are constantly innovating and coming up with human-centric solutions that address the ASRH sector for young people. And then our vision is a democratized, localized, and mutualized HCD stroke ASRH field. Our mission is to unite our global actors to elevate young people's agency and systematically transform reproductive health outcomes for adolescents. Background. So in March this year, Kenya got, I remember it was around the 9th or 10th, we had the first ever case for COVID-19 in Kenya. And as we all know, or as we've all seen across the globe, things have really changed, and organizations and individuals are being forced to rethink service offering. And so for us, it was important to think about how do we, how do we make sure that as much as everything that is currently going on, that young people still continue to be the center of the activities and the services that we're offering, and how do we make sure that organizations working in the ASRH sector continue to offer services. But most importantly, we wanted to understand how might we synergize, amplify, and support solutions and efforts for COVID-19 ASRH response. And so we hosted a brainstorming session. It was a virtual call. At this point, travel restrictions were already in place. So we had a virtual call with various partners, as I mentioned earlier on, implementers, designers, young people, and we wanted to understand how are they currently going about service offering, but also how do we continue to make sure that ASRH services are something young people and adolescents continue to access even during a pandemic. And so out of that call, we were able to, in partnership with Billion Collab, Billion Collab is an initiative by IDEO.org. So we put together an online survey to help us narrow down on a design challenge. So it was purely done remotely. So we put together a survey, and then there were about 6 topics of interest that came off the initial call that we had. And then on top of the list was self-care, and self-care is an important topic, especially at this point, considering that a lot of hospitals, a lot of organizations and government and Ministry of Health, they're focusing and giving priority into COVID-19 cases. And we wanted to make sure that young people can still continue to access these services. So self-care came top of the list. And then we did go through a series of asking partners to apply, interested partners and individuals to apply to participate. And after a very thorough collaborative process in partnership with IDEO, we emerged with a team of 4 organizations. So HCD Exchange being the convener, and then IDEO.org bringing in the design, the human-centered design aspect into the design sprint, and then JPEGO works as an international NGO that is already running programs on various topics on ASRH. And then Maisha Youth is a youth-led organization that is currently working on a lot of programs that addresses young people needs. In their hands is a digital platform that has a key focus on girls, and what they do is they provide services through a digital platform to young girls. And so by coming together, we brainstormed on ideas and then built some very rough prototypes. We went through a very iterative process, received feedback both internally and externally from young people, but also from other organizations. And at the end of this, we were able to come up with a solution that we're going to be walking you through in the next couple of minutes. And so what you're seeing on the right is us in action, some of the initial concepts that we had. And then what did the sprint look like? How did we do this? So it was 3 weeks. And then on the first week, it was a lot of onboarding and ideation. So kickoff workshop with all the partners, and then introduction to remote collaboration tools. Remember, we are working at a point where movement is restricted. And so we needed to make sure that we have the right tools in place to be able to collaborate with people from different countries. And then ideation and prioritization workshops. So this was mainly to help us narrow down onto the problem statement, but also the target group that we are working with. And then the next week was mainly user feedback and testing. So as I mentioned earlier on, it was a very rapid design sprint, and we needed to get to a solution by the end of 3 weeks. So by week 2, we had already come up with ideas. And so what we did is, using our own internal team members, but also external members of the community of practice, we were able to share the concepts and also get feedback. So we created the prototypes and then recruited the research participants. And then we did a call with a larger group to unveil the initial prototype, which had already gone through a very iterative process. So we would actually work during the day, and then by the end of the day, we have a newer concept or a more refined concept of what we've been working with, or based on the feedback that we received from users. And then the last week was mainly refinement and the final, and packaging and putting together the final deliverable. So we did collaboratively again, refine the prototypes based on the feedback that we had been receiving. And then we created the final go-to market solution. And then, of course, hand over to the implementing partners. The implementing partners in this case were the organization that were participating in the design sprint. And where we are with the solution that came out of this design sprint is we are currently running a live prototype of VoiceUp. And the Maisha Youth leading this because they are the youth-led organization, but we're having a lot of conversations with other partners that are interested in working or sort of using VoiceUp as a platform to share information. I know you're probably wondering what VoiceUp is. We are getting there. And then what exactly did our remote collaboration look like? So we used a lot of tools, but these are the 3 main tools that I would highlight today as one of the key tools, some of the key tools that enable us to work together and collaborate remotely. One being Miro. Miro is a collaborative, I call it like a huge canvas that you can literally do anything. And so we built the entire design sprint through Miro. We would put concepts there, we would get feedback, we would conduct interviews and upload that content on Miro. And then of course the output of that would be then moved into the live prototype that we are currently running. And then for communication, Slack offered us that opportunity to be able to share working documents, communicate. We ran, like the screenshot you're seeing on the screen, we ran some polls and survey just to make sure that we are keeping that workshop environment, even though we are all working remotely. So we ran some polls on Slack and people were able to vote on concepts that they were excited about. And then Zoom, of course, being the video and audio communication tool for our meetings and sharing the concepts with users, but also internally with within the team that was working on the design sprint. And then, yeah, so what is VoiceUp? I'm gonna hand over to Rashid, who is with me on this call, and he's gonna be walking us through what VoiceUp is. And this is an output of what I've just walked you through. Over to you, Rashid.
Thank you very much for that, Marianne. And before I begin to actually talk about Voice Up, I'd like to just invite you to think about a young girl who has probably left the house for a few minutes, hours, to just go and hang out with the friend or the boyfriend. And in this point where, or in this moment in time where they were hanging out, they possibly engaged in sexual intercourse. But this girl still lives at home with their parents. This was the only day that she could leave the house. And now she's back home. They probably did not use any protection. And so she needs to access something like an emergency contraceptive after that. Or even before going there, she needed to access like an actual condom. So think about this, and then think about, and as has already been alluded by the other presentations, how this COVID-19 pandemic has actually elevated the issues that are around youth-friendly, access to youth-friendly services by young people. And the fact that at the moment, the healthcare services are really strained trying to respond to the COVID-19 pandemic. And so every other thing, especially access to services for young people, has really been put in the background. And hence, through, as Marianne has very rightfully introduced, through a lot of conversation and iteration and ideation with different partners, this is what we came up with, Voice Up. So next slide, please. So what is Voice Up? It's basically just a resource with different downloadable assets, both in audio, in visual, that really just begin to have those conversations or present conversations around some of these different issues and things around sexual reproductive health and rights for young people. And as in the very first presentation, Ellie and Abigail were talking about, is that there's a lot of non-factual information out there. There's a lot of myths and misconceptions that are really affecting the quality of content that young people are accessing, especially when it comes to SRHR. And this made even worse by the fact that SRH is still a taboo conversation in a lot of our communities. And so Voice Up now just steps in to fill in that gap, where we have audio assets and we have visual assets that really begin to spark those conversations between young people, and also assets of audio assets that are presented by the providers themselves. All the assets within the platform Voice Up are freely available, and they're available to download, to contextualize in the different spaces that young people are found. And in addition to that, Voice Up also tries to, connect young people to youth-friendly services that are near them. But as Marianne said, it's still in the live prototyping session, so we continue to build out the assets within the resource. Next slide, please. So some of the assets that we already have within this space are, some talking about relationships and young people. We have another just bringing in the conversation around self-care and calling that Know Thyself. We have talking or giving the factual information around contraceptives, which in this space we call it contraceptives, wordplay. And then, again, just another space where we're inviting young people to talk about their experience with self-care products. Just how was it for you? Where did you access this? How can me as a young person also be able to access these different assets? And one of my favorites is a campaign that is dubbed the hashtag Come in Peace. And here is really just to, again, reinforce the whole messages around self-care, especially in talking about HIV prevention and using SRHR commodities to keep at bay and plan for pregnancies. And I would now request Mary to play one of the assets that we have from Voice Up. So Marianne, please.
Yeah, so we're gonna walk you through what Voice Up platform looks like. So this is, if you can still see my screen, this is the landing page, and we only have 4 categories at the top, one being the assets, and then youth-friendly services, and inspiration, and then about the platform. As you scroll down, you're able to see some of the assets that Rashid talked about. And so I want us to check what's in here together. And so as you click on any of these categories, you're able to access, audio clips that you can download and use on social media. So let's hear this one.
I have a boyfriend and he wants to have sex. I can only find information about contraceptives. What if I'm not ready to have sex? What can I do? And if I end up having sex with him, how do I protect myself from using the contraceptives my friends keep talking about?
Want me to take you through ABC. ABC means abstinence, being faithful, and use of condom. It's a way of self-care where you can be able to take control of your sexuality and just take charge of your life. So when we say sexual abstinence is when you don't have sexual intercourse. Anybody can.
Yeah, I'm not gonna play the whole clip, but
my girlfriend is not good at remembering about her pill, and she has made me go buy the EC for her. But sometimes it's like every weekend. Since she's taken it many times, is it like the pill?
So let me talk about emergency contraception. What is it? That is the first question. What is EC, emergency contraception? This is a type of a contraception that can be used to prevent unintended or...
All right, Rashid, continue. I just wanted to make sure that the audience gets to hear the kind of content that we have.
Yes, thank you so much for that. So then the question then becomes after that, what's next for Voice Up? And I know Marian, you'll get to talk about the rest, but for me as a young person, I would love to say that interacting with the content as Maisha Youth, we believe that there's so many different ways in which this can continue to grow and reach out to young people. And some of the conversations we're already having within the team is how do we also get this on a USSD platform for young people who are not able to get on a website and can actually just, use their feature phones. And then beyond that now, how can we make these resources or this platform to be able to roll out in other countries, contact with content contextualized to that situation. So it becomes a Voice Up /Kenya, Voice Up /East Africa, Voice Up / different contexts. Yes, and over to you, Marianne, to wrap up. Thank you very much.
Thank you, Rashid, for that. The next things or what we have in the pipeline for Voice Up is we will be having a show and tell, more of an in-depth session of what we just had, sharing about Voice Up, but also getting the larger community of practice to contribute and share ideas on how we can continue growing Voice Up. I'm gonna drop the link to register on the chat section, or if Maxi, I see on the call, if you can drop that one for me. And then we will be launching a Voice Up working group. As I mentioned earlier on, HCD Exchange is a convener of the community of practice. And so we want as many organizations and individuals contributing into growing what Voice Up will become. And then we will definitely publish our learnings for the larger community of practice. They will be available on both Voice Up and our website. And then we are looking to onboard more partners and then adapt this in various contexts, as Rashid mentioned. And then eventually we want to create and advance principles and practices to ethically and effectively engage youth in HCD efforts. We are out of time. Yeah, but that's it from us. Thank you so much for listening in.
Great, thank you so much, Marianne and Rashid. And, we're concluding the session, but I want to thank all of our presenters and all of our participants for a rich and insightful discussion today on sexual reproductive health and family planning during COVID-19. Thanks to your presentations, we learned about ways to adapt family planning interventions for COVID-19, regional and country responses to the COVID-19 pandemic on maternal and newborn health services, the power of collaboration to unite and mobilize our communities to support adolescent sexual and reproductive health. As we conclude this session, please head back to livesinthebalancesummit.org to join the closing plenary. After the plenary, we will also have an optional networking session, so please feel free to join that as well to continue your discussions. Thank you.